Okay, so we will see the pre-examination phase in this 1 hour and relating to the standard. Why is pre-examination given such an importance? For ages, we know that this is a problem area, and we keep reading that most of the errors occur in the pre-examination, followed by post-examination, and the least in the examination phase. Agreed. Why it still happens to be a problem? And in recent days, we see that a lot of changes have happened to the sample collection process. We have independent aggregators getting in, samples flying from one corner of the globe to the other corner, so adding to the confusion. So why this phase is error prone? Too many people are involved. Some, maybe many, are untrained. It's outside the lab's direct control, except for some hospital labs. There are too many variables with respect to the tests, the departments, and the analytes. The pre-analytical phase has to cover all these variables. Different tests have different requirements, and different departments have different requirements. The chemistry looks at the analyte integrity. Microbiology looks at the pathogens that need to be kept under check without multiplying during the collection and transport, and molecular looks at the stability of the nucleic acids that it's going to work with. So too many variables, and everything has to be addressed in this one pre-examination phase, and which is not under the lab's control in most of the cases. And there are challenges in training and competence assessment. There is no standardization between labs. Nothing can be compared. Okay, X lab is doing like this, so can Y follow that? No. And there is absolutely no quality control mechanism for an ongoing error detection and then immediately correcting it and then making the test useful. So with all these problems, we have to continue with pre-examination phase. Now, in this time, what is allotted to me, I'll try to address the different ISO standards on pre-examination processes. There are many available now, and outline 20658 that has been allotted to me. This is a full standard by itself, so I will just breeze through the standard and focus on some common blind spots. In the sense, what has been overlooked in the last decade or so, ever since we started our laboratory accreditation and QMS implementation, there are some areas which have been overlooked. So we'll focus on that as to how to address them and see how we can ensure the quality in the pre-examination phase. Right. The definition, the first definition as it goes in the 15189. The process that starts in the chronological order from the user's request and ends when the examination begins. In between, what are the activities sequentially? One is the examination request, preparation and identification of the patient, collection of primary samples, transportation to and within the lab, depending upon the type of laboratory, and it ends with the time the test starts. Right. ISO 15189-2022 7.2 clause number addresses pre-examination processes, which covers laboratory information for patients and users. That is the probably what we call commonly as the directory of services, and also patient information booklets, and then the request, that is the test request form, which has to be filled up. What are the contents? Then how to collect the primary sample, sample collection manual, how to transport either within the hospital or within the lab or from outside, packing instruction, transport instruction, within what time it should come, what are the temperature requirements in some form of a SOP or a or part of the sample collection manual. Then how to receive, what are the rejection criteria. And then if there is some kind of a storage required prior to testing, for example, if there is a batch testing, then what are the conditions? And if some centrifugation has to be done prior to testing, either in the lab or at the location where it is collected, what are the instructions? So this is how 7.2 covers everything. Practically, it covers everything. There's nothing left. And it also says that the risk identification and patient care has to be applied throughout. Keeping the patient care in mind, risk identification has to be done throughout, which is part of the standard. Now, what are the different ISO standards that address examination process, pre-examination? 15189 is the document based on which all of us design our quality system and perform our testing. ISO 20658 is another standard that addresses collection and transport of samples for medical lab examinations, and that is the topic for today's discussion. This is an expansion, so to say, of 15189, expanding the activities from the beginning to the end for a routine laboratory that performs chemistry, hematology, routine microbiology, routine histopath, etc. It is very well documented with the quality systems essentials in place. The second standard is 20186. If the lab is doing molecular in vitro testing using venous blood as the sample, then this standard has to be utilized, and it has 4 volumes. One is isolated. When the lab performs testing using isolated cellular RNA, then it will follow volume 1 for pre-examination requirements. Volume 2 covers genomic DNA testing. Volume 3, if the sample is a cell-free DNA from plasma on which the test is going to be done. And volume 4 is in situ detection techniques. Then the next standard is ISO 20166. This is a molecular in vitro test again using formalin fixed and paraffin FFPE samples. Again, it has 4 volumes. One is using isolated RNA as a sample for testing, 2 for isolated proteins, 3 is isolated DNA, 4 is in situ on the paraffin blocks. There is one more, ISO 23118. This is for pre-examination processes. Again, molecular metabolomics in urine, venous blood, serum, and plasma. If these are the samples, then 23118 will be in use. ISO 4307 is for saliva, where isolated human DNA from salivary samples are used for various molecular genetic testing. So many standards are available from ISO, but we are going to focus on 20658, which is the general document that covers everything that a laboratory should be doing. And this is the one that is referred to clearly in ISO 15189 under the 7.2 that the lab may please refer to these ISO documents for details. Right. It is not necessary that the lab should own a copy of the standard, but it is better if the lab has. Nevertheless, I will be covering all the clauses here. So let us see. Before we start, what are the different types of sample collection centers? One, starting from a fully lab governed sample collection till a completely independent, so to say, the B2B model. A hospital lab can be, or a standalone lab also, which caters fully to walk-in patients, is fully managed by the hospital, by the laboratory, where the entire sample collection is monitored and implemented and monitored by the lab, testing lab. In the hospitals also, there is some area where the lab doesn't have its control, like the emergency services, sometimes the wards where the samples are collected by nurses or in the OTs. These are the areas, it's still a little outside the laboratory control. Partly managed by the lab, second category, where there are walk-in patients and there are also samples that are picked up by the laboratory from registered clinics or labs. There is some amount of loss of control with respect to sample collection, but still the lab is familiar with the clinics that are registered with it. So some amount of control is possible. Now, the third one is entirely outsourced to a single agency. The lab outsources to a single agency, which will do the collection and transport in its own vicinity or little accessible areas. Here again, the lab can directly talk to the collection agency and tell the requirements of what it wants from the sample collection facility. And there is the last one, which is mushrooming now. There is absolutely no control for the lab. The lab receives samples from multiple clinics randomly, multiple labs, again, randomly from all over the country or from outside the country. The transport may be owned by the lab or it may be outsourced. There are many aggregators who collect samples, but then they don't cater to a single lab. Again, they divide the sample, divide means they allot the samples in batches. This will go to X lab, that will go to Y lab, depending upon various business agreements. So this is another model which is very common nowadays, and where the testing lab is at a loss as to whom to communicate with, except that there are commercial agreements. The lab knows that it has to receive and perform the testing. But standard says, whatever be the type of pre-examination phase, the onus of ensuring sample integrity and correctness lies with the testing laboratory. The laboratory cannot disown, saying that this is B2B and we do not know what's happening at the collection. We only test as received. Sometimes they even give a disclaimer in the reports that test is done as received at the laboratory, claiming that we do not own anything prior to that. That is not acceptable. It is the laboratory's responsibility to ensure that whatever it wants to ensure the integrity of the sample. By integrity, what we mean is the sample should just be a representative of what it was in the body at the time when it was collected, without any loss of analytes, without any loss of matrix. So the lab has to take ownership and train. So that is the requirement for the lab. Now we'll go to 20658. What are the requirements? Number one, as usual, like any standard, you have the scope first. The scope says that this is applicable to the medical labs, the testing labs, and service providers who can be independent of the medical lab. So the collection agencies or the collection companies will follow this standard, and the responsibility of the testing lab is to ensure that these people are doing that. It's like it's a service agreement. During service agreement, one needs to ensure that these conditions are fulfilled. Right. Healthcare workers or independent collection. It is applicable to biobanks also. Right. Normative references, we can skip. Terms and definitions are also there, like 15189. There is only one definition which we can read and remember is facility. Facility is defined like this: entity involved in the collection and transport of samples to a medical laboratory, which may be a mobile facility, it may be a permanent facility, it may be a temporary facility, it could be a home collection. By the word facility, it means the sample collection and transport organization. Right. Now coming to the general, this is exactly structured like 15189 2022. So the 4 general requirements starts with the ethical conduct, impartiality, and confidentiality. Ethics. This is actually one area which is generally not addressed even properly in 15189. What the labs do is generally they write a statement that the laboratory practices impartiality as a policy statement, but how is not never written. Second is, for confidentiality is concerned, there is a statement signed and taken from all the staff that they will ensure confidentiality and they will not disclose it to anybody. This is just not enough. What is required is a risk assessment across the laboratory's process, starting from patient identification, test request, till reports are released, looking at the processes, what are the points where there is a likelihood of an impartiality or confidentiality. For example, let us see it's an aggregator. How he will flout impartiality. Depending upon, again, the contracts, which financial contracts, he might choose to send some samples for the same test, for the same analyte, to a lab with a inferior methodology, another one with a state-of-the-art methodology, without any information to the patient or to the user. And that is not ethical. If you have informed and say that I'm going to send this to a procedure which has a lower performance characteristic than the one that is currently in vogue, this has to be, this loss of sensitivity, loss of performance must be made known to the user. Without that, if the sample collection facility or the testing lab decides on its own, even in the let us say in a testing lab also might decide that these insurance patients, we will do this test which are a little cheaper, or if they are self-paying, then we will do. These practices are seen. So it has to list out the practices and say how the impartiality is not flouted. Same way, it also has to go through the entire data collection procedures, then the documents and records that it creates and the accessibility to others, and ensure that the confidentiality is maintained and how it is maintained. These kind of risk assessment is generally missing. So I thought I would make a mention here. And it's specifically mentioned in 20658 that the lab has to ensure, and it also has to look into privacy, of course, at the time of collection, then confidentiality, and taking into account cyber security, because the LIS, the testing labs LIS could be very much different from the software or the system that the collection center or the facility uses. So this is very important, which is generally not given much attention. Safety, courtesy, respect to patients are generally addressed satisfactorily. I will not touch it. I'm just showing the structure. Right. Under then class 5, structural requirements. Under structural requirements, the legal entity. Okay, it has to be a registered entity. Facility manager, which is lacking. Now, facility manager has to be identified for a pre-examination phase. What is important is this facility manager, his duties, his or her duties, competence required, his training, qualification, everything has to be clearly written. This person should be in a position to interact with the users and advise also on the type of examinations. Again, it's a weak area. That's why I have highlighted in yellow. Why? Because the testing labs, the consultants generally confine themselves to the testing area and do not get involved in the pre-examination, except maybe some training occasionally or writing an SOP. But on a day-to-day basis, the standard expects that there should be a facility manager, even in the testing laboratory. You may call him by any name, facility in charge for pre-examination, who will own up the complete activity relating to this and manage the organization structure of the facility. Advisory services also has to be taken care of by the pre-examination facility. And then risk management is another area. Risk management in terms of the general risk, safety risks, and include biorisk. There is a document from WHO on biorisk assessment, which was released subsequent to COVID, how to perform biorisk assessment in a laboratory, including the collection. So what are the types of tests? What are the type of exposure the people can have? For example, the lab can collect sputum sample for tuberculosis, example. So how do you collect? And then the next person also has to go and collect. What if the first one was positive and you still have some of the bacteria, bacilli in the room, right? So that is a risk you are giving to the next person, how the lab is going to address it. So this is just an example. Like this, the lab has to perform biorisk also in its collection activity and make a appropriate note and take action, train people on that. And emergency preparedness, that we know all the disaster management protocols. I wouldn't dwell much on that. And then we go to the next. Yeah. Under resource requirement, class 6 resource requirements, here 6.2, which is personnel. The personnel demands that the number of persons who are connected with the sample collection and transport activity should be proportional to the activity, the number of samples they collect. One. Second, the qualifications have to be defined. The training should include, in addition to the specific sample collection activities, technical, emergency management, safety, infection control, LIS. All these training are required. Then the competence assessments have to be done as per the policy annually. Then the job descriptions have to be clearly written to them as to what they can do, what they cannot do. Like the person who is doing a phlebotomy sometimes may not be allowed to do let us say, an esophageal sampling or a molecular test, which are very precious. So this authorization, job description, and appropriate authorization also has to be given, like the testing laboratory, in the pre-examination phase also. And it goes without saying that the lab has to make sure that these are implemented even if it is an outsourced activity for the laboratory. So authorized, just to expand that, authorized qualified competent person have to be there for pre-examination process. The list of authorized phlebotomists be available with the laboratory so that it can always keep a check on unauthorized persons collecting the samples, which is very common, very common. Random phlebotomists collecting samples is very common nowadays with aggregators who do the home collections, right? Whoever is free on that particular day working somewhere else would come and collect without even knowing for which lab he is collecting or for which type of test he is collecting the sample. I'll come to that a little later. Then the qualification training, competence assessment records have to be there. The audits have to be done for pre-examination, the facility also. Safety and emergency drills done specifically. Then the transporters also, packing, safety, infection control, how to manage accidents on the way in case of a accident to the sample. These have to be, they have to be trained on that, and training records maintained. Reception personnel who receive the sample, authorization for them who can receive sample, and use of checklists to receive the sample, and their ability to communicate. If something is not okay, they need to communicate with the sending the sample collecting facility, and then immediately take action without waiting for the quality manager of the lab to come and take action. These people have to be enabled with good communication and information. Then queries answering, the same thing. That is why the facility manager is required in case somebody wants to know what test do we need to do for, or what type of sample we have to do for this particular test. Then this person must be in a position to guide them. Then these have to be included they have to be included in internal audits, which is again a weak area. Generally, the reception personnel are not included in internal audits. Right. Next, the resource requirements, okay, these are generally taken care of, comfort, patient safety, how they are seated, all that. These have to be ensured in mobile clinics, mobile sample collection labs, and also in home collection. Home collection, for example, the patient may not have a comfortable place to place his hand and submit himself for a venous collection. So the phlebotomist who visits home has to take all this along with him so that the patient is made comfortable and then sample is collected easily. And of course, they have to be trained well in emergencies management and safety, biomedical waste disposal, everything. Okay. Now coming to the equipment, reagent and consumable 6.4, exactly like the 15189 class. The standard says that the equipment used for collection should be capable of achieving performance, maintenance, and calibration. Is this a new standard? Is this a new class? No, definitely not. 15189, all the versions, right from 2003, say repeatedly that the equipment have to be capable of achieving performance and it has to be validated or verified. This has been there all along. But all the labs restrict this only to the testing area. And sample collection, there are many equipment that are omitted or overlooked. So when we specifically look at 20653, then it turns our attention to what is the equipment that are possibly used in a collection facility. So we will see that. Manufacturer's intended use of a device shall be followed, it says. Now, what are the equipment? The equipment that are used in a sample collection facility, number one is a collection tube system. Collection tube system, that is the tube, its compatible needle, the safety device, right, and the connecting device of the needle to the tube. All are a single unit. The manufacturer recommends them as a unit, and that is a collection tube system as a single device. Second, pneumatic transport system. I'm yet to see a lab, or maybe hardly a handful of labs consider pneumatic transport system as an equipment and do the validations. So that is the second. Third, of course, is a centrifuge if it is placed in a facility where, especially for coagulation and all, the lab, the collection facility has to centrifuge and send the plasma to the laboratory. So the centrifuge that is located in the facility. Then deep freezer and refrigerator where the samples will have to be stored. Then room temperature. Room temperature in most of the collection devices, it is said room temperature, and room temperature by definition is 15 to 25, right? So anything more than that has to be automatically not suitable. So the collection facility also need to monitor its room temperature, because there are times when the temperature goes to 40, 50, and that can definitely affect the gels that are used in the tube, or even the other collection devices used for microbiology and molecular, the transport media. So the room temperature has to be monitored. The refrigerator, deep freezer, they all follow the regular 15189, their maintenance, their calibration, their routine records, goes without saying. Then sample transport boxes. Sample transport boxes may come with an inbuilt thermometer and a digital display, or the lab may put a thermometer, or the lab may use a data logger for monitoring the temperature throughout, or the lab may also use single-use temperature stickers where it will indicate whenever the desirable temperature has exceeded the limit. So all the options are there for transport boxes, and the transport boxes have also to be validated. Suppose you maintain 2 to 8. How many ice? The lab may use a vaccine carrier, I mean, the insulated box, if the transport is locally done, no problem. But then it has to validate how many the gel packs are needed, right? And how long they should have been frozen to be able to impart that kind of an atmosphere inside the box, and what is the temperature achieved and how long it will remain without any change, because after all, anything over a period of time will change. So how many gels are required, how many gel packs are required, and how long, what is the temperature reached, and how long this temperature will remain stable. This has to be validated by the laboratory, and accordingly the boxes have to be allotted for different distances. Very important, and which is generally overlooked. So by the time the samples come to the lab, they are either 15, 16, if they have actually to be between 2 to 8. And the receptionist just looks at it. There are ice packs, tick. Checklist is ticked. Ice pack, yes. Is it cold? Yeah. You check with the back of your hand. Yes, cold. Or and then take it for inside. And even if there is a marginal change in temperatures, people don't really reject it. That is a very common practice that we have seen. So this has to be done. Then, of course, the computers that are used in the facility, or it could be an LIS also that is used, which has been linked to the testing facility. These are the different equipment, and all have to be verified. And I will go to sample collection tube. This is again an area which is overlooked by most of the labs, and we see a lot of collection tubes in the market. How are they selected? Most of the labs do not know what was the basis of selection. They just say, yeah, management gave it to us. Then their first requirement is these tubes, the venous blood collection tubes, have to be manufactured as per ISO 6710. So if that is, the manufacturer has that, the first point is taken care of. Otherwise, do not buy tubes that have that come with no certification and no quality statements, nothing, right? And they have to be verified before implementation. How does one verify? There are the tubes that are validated extensively and approved as IVD devices generally have a what is called a white paper, which gives the details of the validation. What are all the analytes they were validated for, and what was the value that was obtained, and how much how it was approved. All that is available. It makes sense for the lab to download them, or even ask the manufacturer. All of them give BD, Greiner, all of them provide you with those certificates. With those, they are not certificates, they are really the white papers. You can go through that and make sure that these tubes are okay for the analytes that you are testing. That is one. And follow and it also comes with a instruction that these tubes, what is the storage temperature and what is the RCF in which they have to be spun, the do's and don'ts are available. Whenever any tube doesn't have these things, it clearly tells us that these tubes have not been validated. Right? What is the big problem? We'll see. So what? We just need one plastic, a lid that's going to be tight, and then the sample has to go in. It's not that simple. At the gross level, what the lab has to say is, are these tubes compatible with the analyzer? It is the job of the lab, testing lab, because the testing lab only knows what tubes are compatible with its analyzer, and make sure that these tubes are either supplied to the facility, or the facility buys those tubes only and sends the sample to you. Then it should also be compatible with the test method. What is compatible for X lab may not be compatible with the Y lab for the same analyte. Common examples are D-dimers, when some labs use plasma, some use whole blood. So if the technician has, the phlebotomist is familiar with whole blood, he will collect and then send. The other one will send a plasma. So these are the issues. It is not the person's experience or expertise at the facility. The testing lab has to clearly communicate that these are the tubes that are compatible and only they can be used. And at the time of receiving also, the lab has to make sure that if the tubes do not have this, then they will not be accepted or at least kept aside for a senior person to, more competent person to decide. Then suitability of these tubes on automated lines. Most of the testing labs today have automated sample internal tracks and also onboard sampling system. They have to be compatible. It's also possible. It depends again upon. It depends on the probe, how the probe moves in your blood sampling system and decides the column of sample above your gel. Without hitting the gel, the sample has to be taken. So there are a lot of intricacies in that. So better to get into the requirements of your automated system in the laboratory and get the supplies that are suitable for your testing from the facility, the sample collection facility. Then inspect the physical defect, of course, vacuum. These are at the time of initial validation. If you are not buying a collection device which is not coming with any approved validation or white paper or the instructions. Then inspection includes physical defects, the vacuum filling, how accurate. And vacuum filling, again, there are guidelines, how much variation is allowed. Generally, about a 10% variation of the vacuum filling is permitted. Then clotting, are there minor clots? Then hemolysis, the safety, meaning the lure lock or the connecting device, how safe is that? And also performance by testing, right? How this should be done, right? Select the tubes which are approved, as I said before, along with the manufacturer's instructions. If the tubes do not come with any manufacturer instructions, such as what is the RCF in which they have to be centrifuged and what are the analytes which have been validated using these tubes, then it is not a good tube. It is, please do not buy that, right? Then because these are things in the pre-examination phase for which we have no internal quality control and no way of finding out whether the analyte is has the same value as it would have in the patient's body, right? That's a big problem. Then why validation of the tubes? Why should somebody validate? When I ask, have the tubes been validated, the lab gets completely angry. Why validate the tubes? It's not required. They have to be. If the manufacturer has not given you a certificate, if you are not in a position to see the white paper, that means the tube is not a validated one and you need to validate them. Why? Because first of all, the quality of the plastic, right? It may bind to the cells. It may bind to the proteins that is there in the sample, right? It may also release small plastics into the sample matrix, which can alter the values of the analytes. Very critical, which we generally do not pay attention. And more so with body fluids. And it can adversely affect the values, the quality of the plastic. Then the stoppers that are used. What is the quality of the stopper? The lubricant that is used with the stopper again can interfere with the assay. Tube walls. What is the surfactant used? Otherwise, your sample will get stuck and then some of the analytes will be selectively lost. They won't be lost totally, the values will be wrong. What is the clot activator used? What is the nature of the gel separator? All of them interfere. The quality of the plastic, as I said, all can interfere with the sample and alter the values. So these are very, very important and they have to be validated by the laboratory. Generally, why the validated tubes are more expensive than the random tubes that are available? Because of these factors, because this quality of these, if they have not been ensured, then you are going to land with a sample that is bad to start with. Second, Then lot verification. Lot verification, especially lot verification, if the tubes are validated, you don't need to do a lot verification every time. For example, if you have a vacuitainer, you don't need to do a lot verification by checking the analytes, do an electrolyte in old lot, 2 lot, and compare the values. That's not needed because they come with a very stringent quality control procedures. Only thing you need to make sure is the tubes are not expired. Expired tubes can be very dangerous even if they are validated. That is one part. Second is this, the lot validation is important for microbiology as well as molecular testing. The swabs, the sterile containers, and the media that are used. Sometimes, the transport media are inoculated at the sample collection and then transported. Sometimes even the plates are inoculated, like the ophthalmology, they are inoculated at the time of sample collection and transported to the laboratory. Their quality has to be ensured between lots because there is a lot of variation between lots. So there are guidelines which the concerned departments can look at. Basically, what should be ensured is the sterility of the swabs and then the color of the transport medium, pH changes, then non-inhibition of growth. That is, it has to inhibit the contaminants, the normal flora, that whether that happens in selective media. Then second is support of the growth. Suppose you collect a swab for chlamydia and send it to the lab, but all the chlamydia that are present are gone at the time of collection itself, either in the transport medium or in the swab, which are not validated by the manufacturer, nor is he aware of this, because many times the swabs are collected, manufactured like your, what is that, matchboxes in cottage industries and then supply to the labs. Again, there is no validation or even the description, the performance description is not given with any of these products, and the labs have to insist on this. Otherwise, you are just going to get culture, no growth, and then you have all that at the site of collection. So that's important. And there is also how to check semi-quantitative cultures. These are available with CLSI. I'm not going to get into the details, but the lab should know that these guidelines are available and they have to be done. And ideally, the lab should supply these things, or it should communicate to the facility that only these swabs which the lot verification done, they are acceptable to us. Either you do it locally or you get it from us. We will send it. So that kind of agreement is required between the testing facility and the collection facility. This is again a very weak area. Have the standard not said that? Standard has said that. 15189 very clearly says all the supplies should be checked for lot verification. Conveniently, we apply it only to the testing area and we don't apply it to the pre-examination area, right? And even during assessment, whatever, they just randomly check some records or lot verification is there. But then if the sample has already been trashed at the sample collection area, what is the point in going ahead with the very sophisticated tests that the testing lab has, right? So these kind of stringent measures have to be ensured by the lab when they are dealing with the samples that are outside its control, not within the laboratory, when the sample collection is not exclusively within the laboratory. So these are few things like the equipment as well as the lot verification of these supplies, which are generally overlooked. Now we go to the process requirements. Here, nothing much, because collection, everybody has a nice sample collection manual, either written or downloaded, given how to collect venous sample, how to collect this sample, everything is there. What is here important is the deviations have to be reported, right? Failures, recollections, all. And if the lab has prescribed vacuitainer collection, but the facility has used a syringe for a particular patient, it's a deviation, it has to be recorded. For this patient, syringe was used because we could not get the in by this method, by our vacuum trainer. Some reason it has to be mentioned. The deviations have to be mentioned. Then test selection required. That always, generally there are no issues. The test request format is given in 15189 and everybody sincerely has been following. Outliers are generally addressed. There isn't much. Then patient identification and reception scheduled. The auditing has to be done. Internal audit to check the if there are identification errors at the reception periodically to see there are no transcription errors that are possible and whether, if possible, they have been effectively blocked. And what are the policies with routine and emergency identification? These are not big issues, generally done. Now, coming to the collection as such, informed consent, what the labs overlook is an outpatient, by the very fact that he presents himself in the lab, doesn't need a consent separately except for the mandatory HIV and any invasive procedure. But an inpatient has the right to refuse testing. So every time you need to explain that this is what I'm going to do and is it okay for you to give your sample. Informed consent is required for inpatients and it's a patient's right. Then the sample collection. Sample collection, the standard says that single-use devices with safety devices on the needle only should be used. So automatically you get into the evacuated tube and the system because of the safety and the risk associated with a transmission of a blood-borne infection. So approved transfer devices should be used if, in case, as a deviation, sample has to be collected and transferred into the tubes, right? Like the lower lock systems. Then identification, generally the labeling requirement. As far as the labels are concerned, when the sample is transported in a frozen condition, the labels should not come off. The labels have to be suitable to withstand the temperature and also the transport conditions without falling off. There are nice nylon freezer-friendly labels available, and for barcoding, they can be used. Right. Sample integrity and stability. There is no other way. You have to just follow the procedures and pray that the sample integrity is there. Otherwise, there is no way you can introduce a control and see whether the sample integrity is maintained in any of these analytes. Package and transport instructions are generally done. Infection control has been there. Right. Now, SOPs for alicotting and traceability generally missing. They have to be written. Centrifugation, attention to the RCF. There is no generalized centrifugation SOP in the whole world. A centrifugation has to be centrifuge specific. The sample collection facility might have a different centrifuge and the lab may have a different. If the lab is not even aware of what is available in the sample collection facility, it cannot write a centrifugation SOP properly. And RPMs are generally to be discouraged. At the site of work, the RPM, the RCF should be converted into RPM, and then for a practical use, it should be available at the site of work. And there is nothing like 1500 RPM for 5 minutes for urine and 3000 RPM for 15 minutes for serum. There is no general rule. It all depends upon the centrifuge. So appropriate formula depending upon the model has to be applied and the SOP has to be written. Otherwise, you will end up with minor clots, cell contaminations, and that is definitely going to interfere with the results. Then storage, pre-transport and post-transport storage, the temperature, it has to be monitored. Then generally no SOPs. Labels, quality of labels, as I said, has to be ensured. Then suitability for add-on test. Also, what are the add-on tests that is possible for this particular type of samples has to be clearly mentioned as an SOP and given to the staff. Then integrity is by periodical audit of the process audit, right? you cannot, it's impossible to have an acceptability criteria because we don't know what was the starting point with the patient. It's only a process audit that is going to ensure that everything is complied with. Prevention only is the way in pre-examination. Right. Then internal transport system. Pneumatic tube transport systems need validation. Consider two situations. There is a hospital which is more horizontal than vertical. Multiple buildings, multiple blocks, maybe 2 floors, 3 floors. So the samples are moved from one block to other at a particular level, but with a lot of bends at different connections. One building to another, there are some bends. From one corridor to another, there are bends. This is entirely different from another hospital, which is vertical. The samples may drop from 20th floor to the lab, which is at the basement, or vice versa, from a collection which is in the first floor to the lab, which is in the 14th or 15th floor. The pressure requirements for the pneumatic tube are entirely different. And these pressures, there is an acceleration, deceleration, and the G is the engineer's problem. They do the G value during their annual maintenance to make sure that there are no vacuum leaks and the G values are maintained. But from the laboratory, what we need to see is we need to do an initial validation that covers all the risks, like what is the travel status of the tubes by volunteer testing. Duplicate samples. One is manually carried to the laboratory immediately and tested, and the other one passes through the transport system, and the analytes are compared for their values, and that should be within the performance character, within the percentage CV that is established in your method validation. As long as that is done, or within the biological variation, whichever is lower, you take that and then approve the tubes to approve the transport system. How long do we repeat this? Whenever there is a major repair, whenever there are additional stations added to that, to the system, or if there is an incident of a some kind of a leak, some kind of a vacuum loss, mishaps, then the validation has to be redone. And for each sample type, the analyte has to be evaluated for the temperature, acceleration. Okay, what you do is you test a duplicate and then look at the values and check whether that is within the acceptable limit. Some of the tests like coagulation, platelet functions, they may be affected very easily. And based on the validation, the lab will make a policy on what tests need to be manually carried, what for what tests the samples have to be manually carried, and for what it can come through the pneumatic transport system. Generally, platelet function tests and most of the coagulations do not withstand this, so they will have to be manually done, because all these movements through pneumatic tubes, the platelets release factors. So, but anyway, the lab has to do a validation and make its policy. Now, management system requirement, which is the last one, which is exactly like the management system requirement of 15189/2022. There should be a collection organogram, there should be policies relating to the pre-examination phase, then the acceptance criteria, stability. Like there you talk about the CV and all, here you talk about the acceptance criteria. The quality indicators specific to this have to be in place, right? And evaluation, pre-examination process has to be periodically evaluated to see the quality of samples. And the persons who are in pre-examination facility should not just collect and forward it. They should be in a position to assess the quality there itself and stop and get a recollection done there itself, so that unnecessary transport and wastage of time is avoided. So that competence is required at the collection facility. And it is the responsibility of the testing lab to make sure that such competence is tested and then relevant records exist and an internal audit is done to ensure these things. So that's these are customer feedback. These are generally done. So it's exactly like 15189. And the standard also has a supplement that addresses collection of non-blood samples like swabs in bacteriology and molecular testing, where the type of swabs are different. So the lab has to ensure that the correct type of swabs are used for different types of testing, and how to collect and transport in a transport medium, refrigeration, then urine, how to collect, 24-hour collection instructions to be made available to the facility, and CSF, how many to be collected and sent, numbered and sent. Like there is an appendix which addresses these things in a as an outline, not in detail. In detail, of course, the textbooks only will have to be seen. But that covers the 20658 standard that addresses the pre-examination activities. Right. Now, what are the weak areas? The weak areas in pre-examination phase is the personnel management. Generally, the phlebotomist who collects, what is their qualification, what is their competence, what is the training, do they really know what sample to collect for which test, or they just collect 3 tubes and then just send it just as in case, like that. So that is a weak area. Then communication with patients from the facility, collection facility, communication with patients and communication with the users. Then selection of the sample collection device. As I said, I'm yet to see a validation for a collection device. Why a lab chose a particular brand of tube for its collection? Never justified. Then the lot verification for collection devices for molecular and microbiology is never there. So you suppose the sample gets contaminated, you don't know whether the swab was contaminated, and the swab and the contamination originated in the testing area, or it was already a contaminated swab that was being used. So troubleshooting becomes absolutely impossible, and the precious sample is wasted. Imagine it's a pus. You will never know what was the pathogen. So lot verification is again not done. Most of the labs. Then validation of the transport system again is important, and it is not done. So if there are minor hemolysis, see, everything need not be visible hemolysis. And if you are not doing electrolyte on that sample, you will never know. Some of the enzymes might have got released from the ruptured cells, and that will interfere with your assays. So validation of transport system is important, and analysis of quality indicators. I'll just address that next. This is a weak area. Internal audit does not address the pre-examination area in detail. Then in disinfection, especially in home collections, mobile clinics, biomedical waste management, these are the general weak areas, and the lab has to give supply SOPs, train, do audits, and make sure that the collection facilities do these activities meticulously. Now, coming to quality indicator, I'll just briefly do that and close. Most of the labs do a sample rejection. Sample rejection rate, target 5%, 10%. Our achievement to 2%, so rejection is fine. No, that is not the way to do the analysis. This is most of the labs do it like that, giving an arbitrary benchmark based upon their interaction with their colleagues. So you have given 5%, I will also give 5%. Right? What is important is it's not the rate. Yes, rate you need to know, but in detail, what was the reason for rejection? Okay, hemolysis. Why hemolysis happened? Right? Was there a deviation? Right? Was there a difficult puncture, difficulty in getting the vein? Right? Or was a smaller needle used? Or was there an intravascular hemolysis? You are never going to solve this problem. So all this have to be analyzed. Why the hemolysis happened and who was involved? Who was the phlebotomist who collected the sample? Is it happening with the same phlebotomist all along? Right? The phlebotomist might move from collection center to collection center, but unless you know who has caused it, you can never train that person and do an appropriate preventive action for the future. Nowadays samples are traveling from far away, and they are very precious. It's very difficult to do a recollection for these patients. And by the time, even if you do a recollection, the clinical situation has changed. So it's very important that everything is done right in the first instance itself. So the root cause analysis. Then what is the corrective action immediately, and how long you are going to follow it for a non-recurrence? This is the way any indicator has to be analyzed, and that's a very weak area in most of the labs. Amended reports due to pre-analytical. Amended report, okay, this is an amended report. I have a audit trail is not enough. If the amendment has happened due to a pre-examination reason, then that has to be again investigated and preventive action instituted for future non-occurrence. Right. Sample collection time is another area where the labs do not bother about sample collection time, billing time, or the sample registration time in the lab. You have lost the precious transport time in that. So that's important. Other things, these are just a list example of what are the quality, but every quality indicator needs to be analyzed on the same lines that I said. Unacceptable samples, errors at registration, corrected reports, misidentification of the patient. Sometimes you might even have to resort to a wristband at the time of registration with a barcode. So many ways are there by which misidentification can be avoided. Then test transcription errors. Patient comes with a written slip. Then it has to be transcribed into your own test request form or into your own registration computerized system. Transcription errors. Incorrect sample type. Then insufficient filling of tubes. Unsuitable samples, if they were contaminated, hemolyzed, clotted, right? Then blood culture contamination rate, the needle stick injuries, spills. These are, there are more, but these are the classical indicators that it's not just enough to calculate the rate and say that this is the rate. Wherever it has not fulfilled the requirement, what was the reason? A detailed analysis is very important, and that is again a weak area in the pre-examination. How to improve? Implement the standards fully. Do a complete risk assessment on all the activities, starting from patient identification to storage, and then strengthen the internal audit, quality indicators and analysis done properly, and meetings with stakeholders to check whether they are happy or what are the issues they have faced with the pre-examination phase. Right. This is just a summary one. On one side, you have the request, and the other side is the start of testing. In between, the collection, transport, storage. The factors contributing are the equipment and reagents, which we have covered, packing and transport, container validation, as I said, temperature monitoring and the time monitoring, then personnel qualification training, then procedures, patient instructions, sample collection manual, special requests, then environment, the right temperature, space, etc. Quality control. Quality control, there is no material that can do a quality control like we have in the testing phase. It's basically the process review and periodic supervisions and deviation or the error analysis. Wherever there is a deviation, the people must be encouraged to record all the deviations, and then analysis of this deviation will lead to improvement in the quality in the pre-examination phase. So that is a nutshell about the pre-examination. If there are questions, you can ask. Thank you so much.